The critically ill mother, Dr. Chandrika.
Good evening, everybody. First of all, I thank Dr. Shobha Gudi for giving me this opportunity to talk on the topic MTP and contraception in the critically ill mother. I think it's quite risky topic to discuss, but still I have made my efforts. First of all, we should know the definition of critically ill mother. Critical illness is a life-threatening multi-system process that can result in significant mortality and morbidity. Pregnant patients with conditions or situations requiring high intensive care or admission to ICU are categorized as critically ill mother. Obstetric patients admitted to ICU present a challenge to the obstetrician. Because of normal physiological changes that occur during pregnancy and puerperium, specific medical diseases peculiar to pregnancy, and the need to take care of both the mother and the fetus. In most patients, critical illness is preceded by physiological deterioration, but evidence suggests that the early signs of this are frequently missed. The Indian law on abortion, IPC 312, says if abortion is carried out in good faith for the purpose of saving the life of the mother, then it is not punishable. The unborn child or the fetus is entitled to protection. There's a dilemma as to whether the life began on earth after birth.
Chandrika,
In second and
Chandrika, sorry for disturbing. You have only 11 minutes, so I think you just straight go into, because you have two topics, MTP and contraception.
so total time is not 15?
No, like in that you already spent 3 minutes.
Okay. So in second and third trimesters, almost all countries restrict interference with the fetus unless it is done to save the life of the mother. And MTP is recommended to save the life or the health of the woman on a balance of probabilities. The causes of admission to ICU can be obstetric, then medical, surgical, or non-obstetrical. The obstetric causes, we can summarize a few of them as eclampsia, severe preeclampsia, hemorrhage, congenital and valvular heart disease, septic abortions and infections, amniotic fluid embolism and peripartum, cardiomyopathy and aspiration syndromes. The medical causes commonly responsible for this are heart diseases, pulmonary embolism, acute respiratory distress syndrome, pulmonary hypertension, severe hypertension and CVAs, infections, renal, acute renal failure and end-stage renal disease, and psychiatric, sometimes psychotic conditions and suicidal tendencies. Surgical causes can be trauma or acute abdomen with acute peritonitis or pancreatitis and intestinal obstruction and perforation. The non-obstetrical causes, mainly asthma, then metabolic like uncontrolled diabetes with ketoacidosis, certain autoimmune diseases, and sepsis due to any infection. Causes for chronically ill conditions, you can list it as rheumatoid arthritis, cardiac valvular disease, slowly decompensating, then hemiplegic patients, then recent MI or angioplasty patients, then cystic fibrosis with severe pulmonary decompensation, various liver diseases and malignancies. The recent concepts in clinical care management stresses upon important aspects like ventilatory strategies, treatment of shock, then nutrition and decision regarding MTP, which is very important. Management is a challenge because very few clinical trials are available, as it is difficult to conduct well-structured clinical trials. There are no standard guidelines, and physiological changes during pregnancy add to the complications. High mortality, though most patients are young and initially disease-free, is commonly seen, and safety of the mother is of prime importance. The initial assessment is based on the organ-based systemic assessment, and the criteria for admission is 2 organ which are failing and require ventilatory support. Then multidisciplinary team is involved. The choice of MTP is made after discussing advantages and disadvantages of continuing the pregnancy. The medication list should be readily available in ICU, which are categorized from A to D, and X, which are contraindicated. Treatment of sepsis and shock is also equally important. Shock may be due to many reasons. For example, excessive hemorrhage, sepsis, or cardiac illness. The earliest sign of hemodynamic compromise is tachycardia. Gravid uterus can cause supine hypotension syndrome, so the resuscitation should be done in the right lateral position. Early resuscitation of sepsis using fluid is a challenge, and it should be done judiciously because of the possibility of pulmonary edema. Acutely bleeding patients should receive blood and colloid. Activated factor 7 can be used in PPH to stop active bleeding and to avoid imminent hysterectomy. And antibiotics, which are safe, should be used. When we are monitoring the nutrition and other important aspects, the enteral nutrition is preferred to parenteral, then semi-recombinant position to avoid aspiration. Anti-aspiration prophylaxis like H2 receptor blocker can be used. Then intensive hemodynamic monitoring is very essential. Pulmonary artery catheterization used in patients with severe cardiac, pulmonary, and renal disease. And non-invasive methods are gaining popularity because of reduced complications. So I'll just take a few important conditions, and related with that, we will discuss about the MTP. HELP syndrome is seen usually in the late 2nd trimester and 3rd trimester, and serious conditions develop quickly. So sometimes, even with the treatment, if there is deterioration, termination of pregnancy can be advised. That may be sometimes the only way to solve the crisis. But termination will have certain complications. That is, early termination will lead to severe prematurity. And because of this quick development, the cesarean rate is very high. And also there is high blood loss during or post-cesarean because of the reduced platelets. Aspirin given before 2nd trimester, because of its action on microcirculation, may have an effect on this syndrome. Various liver disorders are seen, like hepatocellular adenomas, intracellular cholestasis of pregnancy, liver transplantation, end-stage liver disease, Wilson's disease, etc. The complications are increased maternal mortality rate, even by 10 to 20%, and poor fetal outcome, and there is increased cesarean rate. Elective MTP discussed along with other options like surrogacy, and we can postpone the pregnancy up to the time of liver transplant. Multidisciplinary team, including hepatologists, neonatologists, reproductive endocrinologists, anesthesiologists, and maternal and fetal medicine specialists are sometimes required. Acute intermittent porphyria is a rare autosomal dominant disease. There are acute attacks of neuropsychiatric and neurovisceral dysfunction. And exacerbation of attacks in pregnancy in the form of seizures and acute abdomen occur because of hormonal changes. And we have to avoid precipitating factors to ensure proper management. Highly aggressive cancers like acute leukemia, lymphomas, and certain breast cancers, where early employment of aggressive therapy is required, creates a dilemma as to whether MTP is to be done or they can continue the pregnancy. Sometimes MTPs are acceptable where cancer care is compromised, or MTP is preferred because of nuclear energy and chemotherapy creating developmental defects or future carcinoma in the fetus. But sometimes MTP can be avoided in less aggressive cases where surgery can be delayed until mid-trimester or even after the birth of the baby, like in some breast cancers. But always treatment, anesthesia, and surgery, all are dangerous in the first trimester. Removing the cancerous uterus in pregnant women may be tragic side effect, but it is acceptable when it is done to save the mother with no intention primarily to abort the fetus. Renal disease carries a significant risk, and the risk is proportional to the degree of underlying dysfunction. Hypertension and proteinuria show poor prognosis for pregnancy outcome. Complications include preeclampsia, IUGR, preterm birth, etc. And a worse renal functions before conception shows increased risk for renal function decline during pregnancy. And dialysis has better prognosis in those where it was started after conception, and intensive dialysis improves pregnancy outcome by controlling blood urea levels to less than 100 milligram per deciliter. And these are the cardiac disease and the classification of the risk according to WHO. From class 1 to 4, it varies from no detectable increased risk of maternal mortality and morbidity to extremely high risk of maternal mortality. The conditions in which the pregnancy risk is WHO 1 is uncomplicated, small or mild, pulmonary stenosis, patent ductus arteriosus, mitral valve prolapse, and successfully repaired simple lesions, and atrial and ventricular ectopic beats. Conditions in which the pregnancy risk is WHO 2 or 2 to 3 are unoperated ASD or VSD, repaired tetralogy of Fallot, most arrhythmias, and from 2 to 3, mild left ventricular impairment, hypertrophic cardiomyopathy, and certain other valvular heart disease, and Marfan syndrome without aortic dilatation, and aorta less than 45 millimeter in aortic disease, and repaired coarctation. WHO 3 includes mechanical valve, systemic right ventricle, Fontan circulation, cyanotic heart disease, and other complex congenital heart disease, and aortic dilatation between 40 to 45 millimeter in Marfan's and 45 to 50 in aortic disease. High risk conditions, contraindications for pregnancy include pulmonary arterial hypertension of any cause, severe systemic ventricular dysfunction, previous peripartum cardiomyopathy with any residual impairment of left ventricular function, and severe mitral stenosis, severe symptomatic aortic stenosis, Marfan syndrome, aorta dilated more than 45 millimeter, and aortic dilatation more than 50 millimeter in aortic disease associated with bicuspid aortic valve, and native severe coarctation. How many minutes more I have? 5 more? No, but it was only a few
Come
more
to the
slides. I'll
topic
just
at all
run through.
because I think methods of termination and
Yeah,
what
I'll
are the
just run through
contraceptions,
the
I think
remaining
that you
slides.
should have highlighted.
So cardiac patients should be referred to hospital for an abortion in certain congenital heart disease, coronary and cardiomyopathy, and valvular disease. So ARDS uncommon in pregnancy, and because of some
I think Chandrika, you can summarize the methodology which can be used for critically ill patients, and
see,
what are the
this is one of the important
complications,
slide, mentally ill and contraception. It's ethical challenge, 2 more slides. It's
I think before that you
ethical
can tell about the
challenge to the
methods also,
obstetrician
if you have a
to
slide.
advise contraception in a mentally ill patient, and we have to respect patient's autonomy and help her avert unwanted pregnancy, assess and treat the underlying cause, underlying conditions, and make her participate in family planning discussions, and in severe impairment, consider maternal health first, and reversible and long-acting contraception is better. And we have to keep in mind that depression do not result from using hormonal contraceptions. So to conclude, ICU to be prepared to manage critically ill obstetric patients, Team approach is essential. Management strategies to be suitably modified on the basis of physiological changes during pregnancy, post-MTP and associated medical diseases. The MTP method to be decided on the individual patient's condition. Contraception in critically ill patients may be of less concern and could be discussed at a later date after settling the crisis situation. There are extreme conditions like Eisenmenger syndrome, which accounts for 8% of congenital heart disease. It is associated with high mortality because the right heart failure and from right to left shunt, it is advisable to avoid pregnancy or advocate MTP to save the life of the mother. But on the other hand, the other extreme like SLE, where remissions are common and patient can conceive, long-acting reversible contraception can be advised. And there is no blanket advice on contraception and has to be tailor-made to every patient and priority after crisis. If family is completed, permanent sterilization preferred, especially vasectomy. Long-acting reversible methods are advisable. Hormonal contraception may be given if they are not contraindicated, and mechanical methods are harmless. Finally, we can say that contraception can be advised depending on the individual case requirement. Thank you.
Thank you, Dr. Chandrika.